Alzheimer's may be an infection we refuse to treat properly. Hello, I am Dr. K. Paul Stoller, and when I wrote a book entitled Incurable Me, the revised edition is called Incurable Us, way back in 2015, I predicted it would take 10 years for it to be recognized that Alzheimer's disease was a brain infection. Well, the decade came and went, and we are still not there yet. So let's turn the clock back to 1913, when Hideo Noguchi found treponema pallidum in the brains of people dying from general paresis. A progressive dementia once classified as degenerative or psychiatric turned out to be infectious. Penicillin later collapsed the numbers. That history is not a curiosity, it is a warning. Today we face Alzheimer's disease. Judith McCloskey proposed in 2011 that at least some cases may represent a chronic neurospiritosis, apparently driven Borrelia, the Lyme disease spirochete, and other microbes. The data have only grown. Yet mainstream research still treats infection as a sideshow while chasing amyloid and tau. Three principles came out of neurosyphilis. 1. Chronic spirochetes can invade and persist in neural tissue. 2. Infection-driven neurodegeneration can perfectly mimic primary degenerative disease. 3. Paradigm change requires hard pathological and therapeutic evidence, not consensus. Those same principles apply now. McCloskey and others detected spirochetes in Alzheimer's brains and showed that Borrelia exposure can induce amyloid-like deposits in vitro. Amyloid V itself has antimicrobial properties. That reframes plaques. They may be an innate immune response to persistent infection rather than the primary driver. If the immune system is walling off organisms it cannot clear, then chronic infection sits upstream of the plaques. Other pathogens keep showing up. HSV1, Porphyromonas gingivalis, fungal elements. Alzheimer's is almost certainly heterogeneous. Infection does not have to explain every case to matter in a meaningful subset. Chronic infection drives the rest of the cascade: microglial activation, cytokine dysregulation, oxidative stress, and especially biofilm formation. Spirochetes are excellent at forming protective biofilms that resist both immune clearance and antibiotics. Persistent inflammatory signaling then destroys neurons over years. Several structural problems keep this hypothesis on the margins. Alzheimer's is heterogeneous. An infectious subset can disappear inside aggregate data. Funding follows patentable molecules. The antibiotics that work against spirochetes, doxycycline, ceftriaxone, and others, are largely off patent. Large, rigorous trials of cheap generics attract little commercial interest. Structural incentive alignment is enough. No conspiracy required. The amyloid hypothesis has dominated for decades. Careers, grants, and institutional frameworks are built around it. Disruptive ideas move slowly, especially when fraud has already contaminated parts of the amyloid literature. Public trust issues around chronic Lyme, historical pathogen work at places like Plum Island, and the COVID-era scrutiny of gain-of-function research further polarize the discussion. Science must stay evidence-based, but transparency deficits erode the willingness to look where the data actually point. What is needed is straightforward: multi-center blinded pathogen detection, stratified cohorts with infectious biomarkers, and randomized trials of antimicrobial or anti-biofilm strategies in early disease. If infection contributes even in a minority, early intervention could change outcomes for millions. Hyperbaric oxygen therapy deserves serious consideration as an adjunct. Elevated tissue oxygen tension has direct effects relevant here. It impairs anaerobic and microaerophilic organisms and can enhance antibiotic killing. Experimental data show hyperoxia can disrupt biofilm integrity and improve antibiotic penetration. It modulates inflammatory cytokines and reduces microglial activation. It supports mitochondrial function, angiogenesis, and neuroplasticity. Spirochetes persist in low-oxygen microenvironments and biofilm niches. Raising tissue oxygen may change the ecological conditions that favor persistence. Combined antimicrobial plus HBOT protocols in biomarker-positive early Alzheimer's patients are a logical next step that has never been properly tested. The most accurate position is not that Alzheimer's is purely infectious, nor that the amyloid model is worthless. It is that Alzheimer's is a heterogeneous endpoint, and infection contributes in a clinically important subset. refusing to rigorously test low-profit antimicrobial and antibiofilm approaches, including synergistic use of hyperbaric oxygen, risks locking us into incomplete models while the disease continues to destroy lives. Amyloid may simply be what the neuroimmune system produces when it cannot resolve an infection. The history of neurosyphilis already showed us that infectious dementias can masquerade as degenerative ones. The burden of inquiry should match the scale of the disease. As of this moment, conventional medicine remains largely unburdened, and that is meant in the most pejorative sense possible. Full paper is in Acta Scientific Neurology, Volume 9, Issue 4. Link in the description.